All right. At this time, I'd like to introduce you to our speaker and the writer of the updates of the Finance 101 Manual, Ralph Llewellyn, the Director of Critical Access Hospitals, a notable healthcare speaker, and healthcare consultant at Eide Bailly. Ralph has more than 25 years of experience in healthcare finance, leadership, reimbursement, and operations. He began his healthcare career as a hospital CFO for a 49-bed hospital with a 116-bed nursing home. His passion is providing innovative solutions to the challenges in today's healthcare environment. Ralph assists providers by developing solutions focused on cost report reimbursement, charge master development, billing compliance, operations leadership, organizational structure, process flow, board education, licensure status, and EHR incentives. He is also a frequent presenter and lecturer on emerging healthcare topics at state and national conferences for Healthcare Financial Management Association, American Institute of CPAs, National Rural Health Association, and state hospital associations. Now I will turn it over to Ralph.
All right, thank you very much. Greatly appreciate the opportunity to get to present this topic to the group. It's something I've had a lot of passion over the years in this specific manual. And what we're going to talk about today is an update, a quite significant update that we've seen in this last year. So first of all, starting out with a little bit of thanks to the Federal Office of Rural Health Policy, because that's where this support comes from to put this together. This was an updated manual that was updated in July of 2018. Typically there are some minor updates that occur each year, but really this time is where we look at some very significant updates which we're going to spend some time on. So a major update came out in July of 2018. First and foremost is it's got a new name. In the past it's been specifically focused around critical access hospitals and critical access hospitals alone, but that has changed now. Now it's got a new name, Small Rural Hospital and Clinic Finance 101. And with that, there's going to be some new areas of concentration. So instead of just talking about critical access hospitals, you're also going to be able to find some information in this manual that talks about prospective payment hospitals. Those are acute care hospitals that are paid on fee schedules and diagnostic-related groups in a prospective manner. It's also going to have a section on the rural health clinics and how those operate and get reimbursed both in critical access hospitals and in clinics. With that, there's a fair amount of new content in just the length. We added about 15 pages of new content, new information that should be helpful for a variety of individuals out there. And when we think about who this is a good resource for, obviously flex coordinators, I think it's a great resource for them. I get a lot of comments from CEOs and board trustees also. Actually, we just shared this at a trustee conference that I spoke at about a month or so ago and got a lot of good feedback as it being a good primer to help people get a baseline understanding of what's going on in these markets, as well as maybe some strategies and some other things that they can do to help improve their financial performance. So I'm just going to kind of walk you through a little bit of just kind of how the report is laid out, how it's structured. It starts out with talking about the government insurance programs, walking through the Medicare program, giving an explanation of what the Medicare program is. A lot of times, individuals that aren't in the hospital healthcare setting don't always understand the difference between Part A, which is the hospital program, Part B, which is considered the medical program, Part C, which would be the Medicare Advantage programs we hear about, and then finally Part D, which is the prescription drug coverage. So we get those covered in there. Also talks about Medicaid. One of the challenges as you work with a variety of different states is each state operates a little differently as we look at things. They reimburse hospitals differently. I can tell you that that's one of the challenges when I'm talking to hospitals in different states, is making sure that we understand how their Medicaid program works specific to them. One of the major updates this year in this one is an updated table. There's a link to a table that walks you through how the various state programs are paying critical access hospitals, because that varies so significantly. That I thought was a nice update. It had been several years since the source documents on that had been available for updates. So those have moved forward. If you haven't looked at that before, definitely a great spot to understand how your state is working and how it operates. It also breaks into some conversation about the various reimbursement models. And so when we look at that, we look at it from a governmental perspective, walking through the variety of methods that facilities can get paid on. So some of this is just a retaining of what was there in the past. Some of it's going to be some expansion. It's going to talk about the prospective payment system. That is the system that pays based off of DRGs and diagnostic-related groups. That's going to be the methodology that's covering a lot of what happens in the smaller PPS hospitals. Swing bed walks through the reimbursement mechanism for swing bed, be it cost for a CAH or a prospective methodology for critical access hospitals. It's going to also get into the cost-based reimbursement of critical access hospitals. And I think that's one of the strong points of this whole tool here, is that it helps people understand what is cost. So in the hospital, it'll talk about what are costs. You know, how does that work? It's also going to have a separate little section on ambulance. While hospitals that are critical access hospitals get cost-based for the majority of their ancillary services, as well as the inpatient and swing bed, the ambulance cost can be handled differently depending on the location of their facility as well as the location of ambulances. If you're the only ambulance service within 35 miles of your critical access hospital, you can actually obtain cost-based reimbursement, which is substantially higher than what it would be if you're taking the fee schedule reimbursement. Not a lot of facilities are covered under the cost-based methodology, but it's definitely something, if you're working in rural, frontier-type states, something to keep in mind as you are working with providers or as you work for a provider. It's going to talk about the differences between PPS and cost-based reimbursement. PPS meaning that it gets paid up front. There's virtually little to no settlements on the back end. Cost-based being based on estimates throughout the year with settlements and other components there on the back end. It'll talk a little bit also about physicians and how they're handled in comparison to just the hospital themselves. Method 2 billing, I think this was one, if you haven't read it in the past or you're not familiar with it, I think this is a really good resource to make sure you understand as you're working with providers, because we have a lot of facilities that still haven't taken advantage of this methodology. What Method 2 billing is it basically allows you to bill physician charges on the same claim as hospital charges. So think the emergency room most often, so you can get one claim out to Medicare. And not only does it allow you from an efficiency perspective to bill out in one claim, but they also give you a little bit of a bump in reimbursement because of the use of that methodology. A lot of times what we'll find is historically providers did not sign up to do this because of challenges they had in their EHR systems, their electronic health records, where the physician side of the billing and the hospital side didn't necessarily talk. But we've seen a lot of advancement in those methodologies, and definitely something that you should be looking and talking to providers as you work with them. I'm going to talk a little bit about the Medicare administrative contractors. Sometimes you'll hear these referenced as fiscal intermediaries. That's what they used to be called. These are basically the face of Medicare in the individual states. So it talks about how they operate, how they work as they work with providers. There's also a section that talks about why critical access hospitals may not make a bottom line. You know, there's a lot of talk out there about, well, critical access hospitals, they get cost plus 1%. Well, there's more to the story behind that. And the things that they need to understand, the things that we walk through are basically that, first of all, you have sequestration, which takes 2% off the top. Well, now you're already underwater a little bit. The other piece that we look at is that not all costs are allowable. Medicare has a lot of costs that they've identified as unallowable, meaning that you can't use them in your cost basis for reimbursement. So your 1% has to try to make up for those. Oftentimes, the amount of unallowable costs that get offset on a cost report can exceed 5%. So if you take that 5%, you take 2% of sequestration, but you get a 1% add back, you're still underwater. Critical access hospital reimbursement is really good about helping protect people from hemorrhaging financially in bad times. On the flip side, it makes it really difficult to make a lot of money in good times because you still just get your cost. It also has a section that talks about the Medicare cost report. A lot of uncertainty and lack of understanding about what the Medicare cost report is. I think the easiest thing is it's like a tax return. Basically, you put in the information about the facility, you figure out how much you should have gotten paid versus what you did get paid, and somebody writes somebody a check. It's really that simple at the end of the day. But this has a little section there to talk about the Medicare cost report, how it works, and then finally, it has a little piece on the rural health clinic billing. Rural health clinics get reimbursed on a cost basis methodology, both in smaller PPS hospitals as well as in the critical access hospital setting. If they're in a PPS hospital that's at least less than 50 beds, they get the same cost-based reimbursement methodology that a critical access hospital would. So that's going to be some of the additional commentary that you will find in the report this year that wasn't there in the past. Next, it's going to move into a section that's just on critical access hospitals. So we're going to have a section on critical access hospitals, then we're going to find ourselves a section on PPS hospitals, the small rural PPS hospitals, and then we'll see a section on the rural health clinics. So the first piece that we're going to walk through is the most important CAH financial indicators. And so where this came from is this came from a 2012 financial summit that I was fortunate to be a part of, where a group of individuals from industry, academia, consultants got together to come up with what are the top indicators. And we didn't really say we needed to have 10, but as we walked through that grouping, what we landed with was, here are 10 indicators that we feel are the ones that you should be monitoring, managing, and trying to work towards. And so you'll see here on the screen, Table B, it shows the financial indicators. This is through 2016. There's always a lag, and that lag is because you have to wait until Medicare cost reports have been filed. So the most recent data that's been released is through 2016. When we first started out in 2012 and we were having our information, as we looked at where those numbers are now as far as medians versus where they were then, we've seen a little bit of improvement in the days in accounts receivable, both gross and net. We've seen improvement in the days cash on hand, where it's actually increased a little bit. Total margin is bumped up slightly. We're down a little bit in operating margin, which is not surprising. I think over the years we've seen some tightening of financial reimbursements. The debt service coverage has been going upward, meaning they have a better ability to pay their debt. Salaries to net patient revenue has been virtually flat. That's one that we were hoping that we would improve by moving downward. Medicare inpatient payer mix has gotten a little better, and the average length or average age of the plant is fairly close. It's decreased it's just grown a little bit over those time period. And then the long-term debt to capitalization, there was some significant growth there, which is could potentially be a little concerning over time. But these are numbers that get updated every year, and then the manual gets updated. It's a great place to look at what the national medians are and how they're trending. The nice piece that I like about this section of the report is that it takes the calculations and demonstrates how they work, and fairly simplistic methodology of just using it more like a mathematical equation in the form of a sentence to kind of lay it out and say, okay, here's how you calculate it. It also talks about, as you can see in this one, is the favorable value. So you see the salary to net patient revenue calculations. Down below you see favorable results would be to be below the median. Then it shows you what the median is. And it'll also talk a little bit about what might be causing the unfavorable value if you're in an organization. Obviously, if we have problems with staffing costs, salaries, it's oftentimes overstaffing, a lack of staff for the given volume of service that's going on. Could be the hourly rates that we're paying or the wages that we're paying, a variety of different pieces there. Improving financial performance, there's a section on that. Now, this has a couple of pieces to it. This section has input from the 2012 Financial Summit that I spoke of earlier. It also has some additional information for the 2018 Rural Hospital and Clinic Financial Leadership Summit that was held this last year. So there's some newer information in here, some new basis for us to be looking at data. And so what it'll have in here is it's going to talk about the 2012 strategies first and kind of walking people through those. First and foremost, the cost report review. The cost report review, the real value in this that it'll talk about is that oftentimes there are dollars being left on the table. And what I mean by that is the work's been done, the staff have done the work, you've recruited the patients in, you've done everything you need to do. Now you get to the cost report, which is where it calculates your payments. But there's a lot of information that goes into that cost report. And just like a tax return, there's a lot of elections that need to be made. And if you don't periodically go through and make sure that you're capturing the right data as well as making the right elections, you have the potential of leaving money on the table. In this scenario, probably want to see people looking at this in depth every couple to 3 years. Charge master review is another strategy. This is another piece that sits on the side of there's potentially money being left on the table. I spend a lot of time, I'm fortunate getting to spend a lot of time out working with providers in their charge master. This, as well as the rest of the revenue cycle, is a major challenge. It's a very confusing item with a lot of changing rules, and there's not a lot of classes or training in colleges, etc., to allow people to better understand what they need to be doing. Charge masters probably need to have an internal update every year or so. Probably every third year is where you're starting to look at. Maybe fourth year is when you're looking at, do I need to have an overhaul, outside look, etc. On the next strategy area is the area of strategic, financial, and operational assessment. And I would say this is the area I've probably seen the greatest growth and opportunity in the industry in the last couple of years, as well as the most amount of action happening. And really what this is looking at how is the underbelly of the organization operating. It's looking at things such as marketing. Are we marketing to pull in these things that we need to do? Do we have a strong strategic plan? Obviously, when you hear the word financial and operational, you're probably thinking staffing, that labor cost, the benchmarking, all of those components. Part of the reason that this has become a bigger opportunity in the last couple of years is because there's a lot of new technology out there, a lot more information that can be gathered, a lot more opportunities to better understand your data and then make decisions off of that data. Revenue cycle management, this is the whole revenue cycle. So this begins at the pinpoint of a patient knowing that they're going to have to come in and have a service done, all the way to the completion of billing, collection, and emptying out that account balance at the end. And Again, this is an area that is got a lot of challenges, a lot of changing rules, a lot of confusion. Almost any healthcare conference you go to, this is an area they're talking about. Unfortunately, I would say this is an area that people do a lot of talking about, but don't necessarily spend as much time putting their focus and efforts in fixing. The big piece about doing revenue cycle management from a strategy perspective is it's typically work you've already performed. It's just now making sure that you're getting everything coded, everything put on a claim correctly. You got all of the right demographics for insurance and addresses and codes and orders, all that, so you get paid for what you do. One of the things I can tell you in the revenue cycle management side where the opportunities are is when we do outpatient coding reviews, we see that probably 30+% of all claims that go out of a hospital go out in air. They're missing something that could have potentially afforded them an additional payment. So that it'll talk some strategy there. Physician practice management assessment. This is a more current piece that we've been seeing more activity in. And this is really looking at managing the physician productivity, contracting, expenditures, process flows, satisfaction, all of those things to build a better mousetrap around the clinic processes. Lean, I think everybody knows what lean is. A lot of times the lean processes come into play when you start doing things like the operational assessments, the revenue cycle management, the physician practice, because we're starting to look at processes. Do we have broken processes and pieces that need to be fixed and organized within our organization? So there's some strategies in that arena. It's also going to talk about the importance of educating your leadership in a critical access hospital. And so when we look at that there, it's the department heads. And I think sometimes we think that, well, don't they get that somewhere else? Do they get in college or whatever? And there's very little training. There's very little training in that area for the professionals that are coming up in leadership in hospitals. Also, it's looking at the board training, making sure that the board understands what they need to know. Do they understand the industry? Do they understand how reimbursement works or does not work, and the complexities and the importance of things like ACOs and other accountable type programs such as patient-centered home and things like that. So a big piece on that. It's also going to talk about strategies in the area of collaboration. And what we're looking at there is collaboration at the C-suite level. Collaboration doesn't mean selling out or affiliations all the time. It could, but it doesn't necessarily mean that. Really, it's looking at things like CEO networks, CFO networks, C-suite networks. And it's not just collaborating the minds, because if we have the CEOs and the CFOs and the COOs together, that's doing one thing. But where the other opportunity comes is sometimes to pool the financial resources, collaborate together to access better resources, more efficient resources that might eventually help you actually decrease your costs, improve your performance, etc. Then we get into the 2018 strategies. Now the 2012 pieces really focused a lot on what I would call lagging indicators. These areas, these strategies are more looking at probably things that if we do these right, they should be the leading indicators that things are going to hit us in improvement in the back end of the process. So what we're looking at there is market indicators. And where you see a lot of this happening now is in accountable care organizations, where you're trying to better understand your market. We should have tried to understand this a long time ago, but sometimes it's hard to get good market data. In the accountable care organization areas, they're getting better data about their patients. They get more complete data about when their patients come to them versus where they go somewhere else. And so this is really looking at that component, looking at things that ACOs would be looking at. This kind of a strategy, if you dig into it, is oftentimes going to lead to a need for more analysts. That's the one thing they say is probably the one big growth area in healthcare right now is in the area of analysts. Not just people that can analyze a number, but actually understand the industry so they can do the analysis and figure out what is probably going on or not going on to cause fluctuations in numbers and appropriateness of those numbers. They added the addition of one more ratio or one more financial indicator. This is the current ratio. Basically, it's just a financing, how quickly or how many times could you pay your current debts quickly. A higher number being better. Operational efficiency. Now, this is getting down into the staffing kinds of things from the strategies. When we think about this, this is looking at benchmarks and what can people be doing to better try to develop benchmarks. The hard part about productivity management is that there is not a lot of general knowledge available in the public for you as far as hours per patient day or hours per test, etc. Most of that data that's out there is proprietary. Sometimes it can be very expensive, and so it's trying to gather that. So some of the strategies we've seen around operational efficiencies is we're working with some states now that states are coming together and self-reporting data into databases so that they can start comparing themselves against financial indicators. You know, which states are doing well or which facilities are doing well in a state on hours per patient day or hours per lab test or radiology. It's kind of taking that collaboration as well as you know, some of the tools you can build to kind of drill towards operational efficiency. Also talks about telemedicine. The challenges we oftentimes have in an operational efficiency is drive times and travel and the ability to get people in. Telemedicine is definitely a growing component. There probably needs to be some changes in reimbursement to make it really make the big turn, but definitely some opportunities for facilities to improve their financial performance through the use of telemedicine, keeping people local, keeping them in their organization. Also a section on care management. In the care management area, you know, you hear about a lot of this in the ACO world. So you hear a lot of these things that tap on that whole population health area. So when you look at care management, you know, you start talking about patient-centered medical home. You know, are you in ACOs? Those are indicators that maybe you're trying to move things forward in the dial. The other thing is then what are the services that maybe you're offering? The two most common ones I see right now are chronic care management as well as transitional care management. The chronic care management is the piece that's trying to keep them out of the hospital, keeping that person with 2 or more chronic conditions going, keeping them out of the hospital, keeping them up with their hospital visit or their clinic visits, keeping them on their meds, really doing a lot of tracking, and that tends to lead to improved market share and a lot of the services that especially our rural providers can provide versus waiting until they have an incident where they've got to go elsewhere. Transitional care management, that's the component that's trying to keep them from being readmitted. This is what they get for that 30 days after an admission, and the facilities that we've seen operating and using those have seen reductions in their readmission. So some definite positive pieces that are going on in that area. Quality performance, this is really tracking and monitoring the things that we see in places such as Hospital Compare. For the small critical access hospital, I'd say this one's been a challenge for providers over time because we're small, and sometimes there's very little data that's actually released because of the lack of information that's available. And I think as an industry, small rural hospitals have also pushed to say, well, that information isn't relevant and you shouldn't report it because one patient can make us look bad. The problem is that now a lot of times there is no data, whereas they can actually find data on the bigger facilities. So there's some concern that if you can find data on some and can't find it on others, is that a negative connotation on those that you can't find the data. So there's a strategy focused around how do I make sure that my HCAP scores and, you know, my satisfaction scores, all those things are as high as they can be. I'm getting all the quality indicators handled and everything else. So I think this is something that facilities really need to look at hardwiring in their organizations. because we need to want patients to have that data rather than to say there's reasons why, excuse me, reasons why we shouldn't have the availability of that data. Community health, another strategy working on the community health. This gets into a lot of things that are probably outside of just the scope of the healthcare provider themselves. So this gets into things like availability of food and housing in the community, access to transportation, the access to healthcare and community-based resources, things that maybe the hospital doesn't have to or doesn't need to provide. The quality of education and job training. This is working a little bit into that whole issue of workforce. You know, do we have the appropriate workforce and all of that in place? Literacy rates, public safety, cost of health care. Also gets into this thing called HCC, which is hierarchical condition category coding. That's the coding that helps us better explain how complicated our patients are based on the diagnoses. One of the things we know is that rural hospitals, because of the CAH methodology of reimbursement, have probably not focused as much as they should have on getting enough of the detail on coding. And when we don't get that there, sometimes it looks like we're not taking care of that complex of patient. So there's some strategies there of trying to show how complicated our patients are, because it can help us as we're working with payers, government, etc., on trying to make sure that we're continuing to access the dollars we need from a reimbursement perspective to provide the services. Last in this area is a section on data management. I don't think any listing today is complete until you talk about the data. There's a huge growth in the amount of data that's being developed in organizations. And so there's data that's flowing through all of the different systems that people have, be it their Epics or their Cerners or their Community Works or their Healthland or, you know, whatever it is. There's all kinds of data that's being captured. But really the strategy going forward is that we need to start turning that data into information. And then as we continue to take that information, we got to convert it to knowledge. And that's where the opportunity is going to be for facilities to better grow and better manage their businesses. And so this is something that maybe 10 years ago, there may have been a lot of question as to what would be the ability of the rural provider to get into these types of technologies just because of the sheer cost. Well, but that's really changed. And so we need to understand that in the rural setting, there is some models out there. There is some technology out there. Simple things like Microsoft BI tools, which cost, you know, I think Microsoft BI runs about $10 a month per user. Not everybody in the hospital obviously needs it, but we need to gather that data because facilities are going to better understand themselves, and they can also use this data when it's time to advocate of why they need more dollars or why they need different rules and regulations to allow them to better provide the care that they've been entrusted to provide. That kind of takes us out of the critical access hospital side, and now we move into this PPS side, the prospective payment system model. So this is the newer section of the report. So we look here at the most important financial indicators, and you're going to notice that they're the same ones. And really this was, you know, we didn't have a summit that went to do this. This was stepping back and saying, what are the tools that make sense? And what I can tell you is that the financial indicators, they're universal. What works in a critical access hospital is also applicable in the PPS hospital because the same indicators will be an indication of strengths or weaknesses within the organizations. Now the challenge that we have today is that while we have the flex monitoring team that develops information and benchmarks and medians and all that great, wonderful information for us on the critical access hospital side, there is no such database or group out there that has been charged and funded to gather that data. So that's the challenge we have today. I would say that that's also in the long run where the opportunity is, so that there's better data out there to allow PPS hospitals to gauge against each other in the same manner that we see the critical access hospitals doing today. Similar strategies, and what I mean by that is that while the reimbursement changes, a lot of the components of what you need to do are going to remain the same. Cost report review is still really important, but it's going to be a little different from the aspect that you're not cost-based reimbursed, but you have slight areas where you might be able to get some additional dollars and cents. There's things like Medicare bad debts and reporting them. The wage index that you report can affect the payments for your whole area. We've got indirect medical education or graduate medical education costs for some, that we see in a couple of rural facilities, not a lot right now. Disproportionate share payments come off of the calculations on the cost report, so there's still some pieces there. The strategic financial operational assessments, those are still really important. The key on them is when you get into operational assessments, if you can find identifications to improve efficiencies, reduce costs, in the critical access hospitals, as you do that, you reduce $1, Medicare probably pays you a little less because your costs went down. In the PPS world, you cut $1, that dollar is usually going to hit the bottom line. So there's a lot of differences just in the impact, but the methodologies are the same. Revenue cycle management, the same complexities. Some people say that, gee, it should be easier to manage the revenue cycle because you're a bigger facility than a CAH. In all reality, we don't see that the size of the facility is really the driver. It's the resources and the processes that have been built around the revenue cycle that make the difference. Physician practice management assessment, same types of things there. We got lean. We have education. That's going to be a different education. Critical access hospitals focus on cost-based reimbursement, how it works in their rural setting. Prospective payment department managers and boards will look at it in the model of how does it work in their world, not the cost-based world, but their world. Collaboration is another great opportunity here. That gets into the, pooling some dollars or networks, and, finally, I think really trying to work on those benchmark indicators, getting something like Flex Monitoring Team built around that. So the interventions, very similar. The financial impacts can be quite different, though, just because of the reimbursement model. Finally, we move into the provider-based rural health clinics section. And this one was a little bit more difficult to kind of start putting together the indicators because they don't, where the other two have their own financial statements because they're typically standalone entities, the rural health clinic becomes a little bit more difficult. So the first thing that they talk about in this section is we've got a whole piece on the background. Helps you better understand the origins of the program. It's a safety net access type program meant to make sure that there's providers out in the rural setting to take care of the needs of the population. When we get to the financial indicators, here's the first really big difference we see from the other areas. Days in accounts receivable, we probably can manage those because most facilities actually track those separately. They'd be able to look at their accounts and be able to look at how many days in clinic days do I have in net and gross receivables. Right now there are no big indicators out there as far as like Flex Monitoring to measure against, but those are definitely something you could look at. Look at trends. If you had a state association, it could be putting that data together to have statewide trends. The favorable direction on these days and receivables would be to be moving downward. Cost per visit. We'll talk about the cost per visit, gives a little bit of an idea of some national numbers out there, but really looking at what's that cost per visit, how are we tracking that over time? Because, while, some people say, gee, I'm getting $250 cost per visit, my neighbor's only getting $150. At the end of the day, they're both getting their cost. So the one's getting $250 is because their costs are $250. When you're measuring the cost per visit, we really should be measuring it with the goal of trying to minimize the growth in that and potentially over time drill that cost per visit down. The reason that's important is that while you get costs from Medicare and you get a prospective payment from Medicaid that's based on historical costs, commercials pay you on fee schedules. And those fee schedules are typically going to be lower than that $150 or $200 per visit. So while you might get your costs back in Medicare, you're losing on the others. That's why that one's an important number to be watching. Medicare payer mix, very similar to what we see in the hospital side. A lower number would be best as long as you're just building volume, not discouraging Medicare volume. Visits per physician, nurse practitioner, and physician assistants. Talks a little bit about needing to manage those visits, because on the cost report, Medicare requires you to divide your costs by the higher of the actual visits or this productivity standard that they've developed. And the productivity standard is 4,200 visits for a full-time equivalent physician, 2,100 visits for a nurse practitioner or PA full-time equivalent. So needing to manage that and monitor that is a great spot to be looking at from a tools also. While the cost report looks at it in the aggregate, facilities probably should be looking at it by individuals so that they can start working on managing the specific individuals that might be causing there to be some challenges in that calculation versus everybody on board. The next piece is that the percentage of nurse practitioner and physician assistant FTEs to the total providers. And what we're trying to figure out there and what we're measuring there is how much of the grouping of the practice in the RHC is mid-levels versus physicians. Because one of the things that we've seen over time is that if you use enough mid-levels, all things being created equal, you're probably going to perform better financially. Now we've got to make sure we take care of all the proper clinic needs, etc. But the more nurse practitioners and physician assistants you can have above the minimum, which the minimum is you have to have one in the clinic 50% of the hours the clinic is open, the more you have there, sometimes the better you can manage your total cost. So obviously most facilities are going to have a physician or two in there, but the one that has 2 physicians and 4 mid-levels is probably going to perform better financially than the one that has 4 physicians and 2 mid-levels, just kind of as a basis. Staffing costs per FTE. This is a great place to be looking at monitoring over time, trending it. If you could build the databases in the state, this would be great. Obviously, the lower the average cost per visit, the better. Finally, the average charge per billable visit. And what we're looking at there is, are we capturing charges? Are we keeping up with what our charge master should be set up for pricing? So a higher number would tend to be indicative of better performance on your charges per billable visit. Could mean that you're capturing more charges that maybe others are missing. Could mean that you have more robust pricing. As long as pricing is reasonable, that would be a positive approach. Interventions here have some of the same similar types of methodology, the cost report review. In this piece, you're just reviewing that section of the cost report, that's the RHC. Within the hospital cost report, there is a small section that's basically a mini cost report in the middle of a larger cost report. And so what you can look at there is the number of visits and the proper reporting of costs, etc. Because here's where, again, if we're not careful, you may have some dollars left on the table. If you're getting hit by the productivity standard, maybe there's some ways to restructure things to get more patients through, etc. Charge master, making sure you have all the right charges set up, have the right price. I find this to be a huge opportunity in many rural health clinics. Oftentimes that is due to the fact that rural health clinics don't pay enough attention to their pricing. They kind of get lazy because, well, they basically take the position that I get paid cost per visit, so my charge doesn't really matter. Well, it doesn't maybe as much from Medicare, although it does a little bit, because when we say cost-based reimbursement, it's 80% cost, 20% charge. So if your charge is too low, you're leaving some money on the table there. But if your charges are lower than the commercial payer fee schedules, you will get paid the lower of, and we've seen some facilities where that has occurred. So definitely an area to manage there when you're looking at interventions. Revenue cycle management, this is the demographics and the billing and all that, really important. Physician practice management, their contracts, productivity. We find there's typically a lot of opportunity to help the practice increase their productivity, see more visits. It's not necessarily making people work harder. It's breaking down the breakdowns in processes in the organization to take advantage of some of those. Lean processes, again, that ties into some of the operations, and then looking at your collaboration. So where do you go with some of this? First of all, I highly recommend you explore the resources on the National Rural Health Resources Center website. I can tell you that probably every few months I go out and just check and see what else is new out there, not just in these two areas, but on the whole website. New tools that come out, new things that are out there. I think there are a lot of good information that's written at a level that the average CEO, CFO, board person, flex person, people that are in the industry can understand and garner some additional information to help them as they work with, or work for an organization in the rural setting, being a critical access hospital, be it a prospective payment hospital, or be it a rural health clinic. So again, great manual resource, flex coordinators, board members, C-suite. The most telling one was just recently, as I indicated earlier, the board members. When we handed that out, I had a lot of follow-up conversation. What I like about the whole manual, I've liked it in the past, I think it's a much deeper model now, is it gives you a really good high level, and then it's got some deep dives. It's got some deep dives and some things to say, okay, here's where you want to focus. Here's where you at least start. And it at least gets that beginning conversations, because any of those that you dig into, you're probably going to need to dig deeper into, but there are definitely opportunities out there. I can tell you that in my experience I've been in this role now for over 20 years, I have not walked into a facility that once you get them to start talking about things like this, similar to these kind of concepts, there's always opportunities. Now it comes down to, do they have the time? Do they want to make the time? Do they have the resources, or do they want to use the resources? Do they have the commitment? Those are the things you got to deal with. But there's definitely opportunities for us to help provide tools for the providers to improve their financial performance and their organizational long-term success. So with that, Kim, I would turn it back to you with some questions, if there's any questions that came through or any questions that anybody online has.
Great. Thank you so much, Ralph. Yes, if anyone has any questions and you're on the phone line, you can press *2 to unmute, or you can feel free to put any of your questions into the chat box at the bottom left of the screen.
While we're waiting for a question to come through, for those of you that go in and get the opportunity to get in front of boards, I would highly recommend that you make sure that they're aware of this, because sometimes we'd like to think that the C-suite gets this information to the trustees, but they don't always. And so I think, if you have an opportunity to be in front of a facilities board, this would be a great tool to bring in and say, hey, here's some information that you may find helpful. I think they would definitely appreciate it, definitely take that as a positive part of the relationship they have with you.
That's a great suggestion. Thanks, Ralph. Junia has a question. Is there any legislation out there that is looking at the non-cost report eligible services for critical access hospitals? For example, allowing skilled nursing facilities, etc.?
Okay, great question. So I'm going to take two twists at that question, because there's a couple of things that are and are not happening out there. As far as if the question is saying expanding the cost basis to other programs such as, let's put nursing homes in there, let's put hospice, let's put home health, anything that would have a separate number, those would be the big ones. And I would say right now that conversation is pretty dry. Really nothing in that arena, really hasn't been for a long time. Now there has been some indication that I just saw recently. I can't remember the exact source of where it was coming from, but there's at least some conversation going on around, are there things that we can do differently on the cost report to offset sometimes some of the negative implications of having some of these non-cost-based items? And what I mean by that is that if you put a nursing home on the cost report of a hospital, what it does in effect is it takes and it absorbs or pulls away some of the overhead expenses, some of the administrative in general, and some of those core shared services. Some of that cost gets pulled out of the hospital and gets moved over to the nursing home. Well, that then, since you're in a cost-based methodology, reduces your reimbursement from a Medicare perspective. And so that leads a lot of entities in the rural setting to say, I don't want to have the nursing home. I don't want to have home health. I don't want to have hospice. I don't want a freestanding ambulance. I don't want. And so there's finally getting to be a little bit of interest in a conversation about, could something be done differently on the cost reports that would not have that negative impact. I think that it's a great starting point from conversation. The challenge is going to be that you're going to have, I think, congressional leadership that will say, yes, we want to do this, and the pushback is going to be on the CMS side, because they're going to say, well, that violates all of the rules that we've ever had on Medicare cost reports, and people will play games. And so I think that's where the challenge will come. I think there's probably some hope in that area, but it's going to take a little bit of work and advocacy from those of us that advocate with congressional leaders. I hope that answered the question. Oh, yeah, and it says something here about a psychiatric unit. So those two 10-bed units, the 10-bed units that are out there, actually I was just on site with a facility last week that was looking at it. Those 10-bed psych services and rehab service units, I don't know how anybody can make money on those. And by make money, it's just, can you break even on your cost? Part of it is the overhead component. The other part is that even from a staffing perspective, it's extremely difficult to manage them efficiently when your maximum is 10, because to hit a bottom line or break even, you probably got to average somewhere between 6 and 7, probably closer to 7 on an average daily census. But even at 6, if your max is 10 and you have fluctuations, I have not seen, like in the inpatient rehab, anybody above about a 5.8.
That's really interesting. Thank you, Ralph, and thank you, Dunya, for your great questions. Does anyone else have any questions for Ralph today? All right. Well, you can always email me if you have any questions, or Ralph. I just want to let you know that the recording of this webinar, along with the slides, will be available on our Help Webinar Playback page. At this time, I ask that you complete the short online assessment for this webinar. Use the links on the screen to register for any of our upcoming webinars or to access our large array of resources, including the Rural Hospital Toolkit and this Finance 101 manual. If you have any questions or comments, please contact me at the email link on the screen. We hope to have you all on future calls. Thank you so much, Ralph, and thank you for everyone for being here today.
Hi, Kim. This is Sally. I'll just, from Rural Health Innovations and National Rural Health Resource Center, I'll just add that, as Kim said, the recording's available, also the podcast and slides. So we encourage all of you, whether you're a network director, hospital leader, or Flex Program State Office, that you can share the recording, the manual, the slides with board of directors or in educational sessions. So it's all up there to be used, and as Ralph said, fits different audiences and allows you to go deeper as needed with different groups.
Thank you, Sally. All right. Have a great afternoon, everyone.
Take care. Bye-bye.
Bye-bye.